Hello, everybody. I'm Dr. Semir Vranic. I'm a pathologist and associate professor of pathology at Qatar University. In this short presentation, I will give you overview over the rule and the testing of NTRK gene fusions in solid cancers with emphasis on soft tissue tumors. As you probably know, NTRK gene fusions have been in focus recently because they became a targets by the specific drugs called NTRK inhibitors. NTRK gene fusions are important because they may drive oncogenesis, and they have been described as a common alterations in some rare cancers, while they appear to be very uncommon in common cancers or common tumors. This NTRK approach with NTRK inhibitors is one of the pivotal approaches, is so-called tumor agnostic treatment of solid tumors, which implies the use of the same drug for the multiple across the different histotypes of the tumors which share the common genomic alteration of or biomarker. Importantly, there is no approved companion diagnostic tests for NTRK therapies at the moment. However, several different methodologies are available for NTRK gene fusion testing. NTRK proteins are very important for the development of both central and peripheral nervous system, and they actually are composed of three different proteins that are encoded by three distinct genes: NTRK1, NTRK2, and NTRK3 genes. As I said, they play pivotal roles in the development of both central and peripheral nervous system. However, these genes and their proteins with tyrosine kinase activity may be also dysregulated in multiple tumor types. The most common mechanism of their activation of tyrosine kinase activity is mainly through chromosomal gene rearrangements. In most cases, it's a 3' region of NTRK gene fusion of NTRK gene that fuses with their partner at 5' region of the unrelated gene, so-called fusion partner. So far, more than 80 different fusion partners have been identified in the tumors. However, novel partners are continuously being reported in the literature, as you will see in the coming slides. This is the overview of the most common fusion partners of NTRK1, NTRK2, and NTRK3 genes in solid tumors, and this is published in one of the seminal papers of NTRK gene fusions in Annals of Oncology 2 years ago. As I said in the beginning, the prevalence is characterized by the common presence of NTRK gene fusions in rare cancers and rare presence of NTRK gene fusions in common tumors or common cancers. That's the feature of NTRK gene fusions. And as you can see on the image, they are very common in 4 uncommon cancers, among which some are also soft tissue tumors like infantile fibrosarcoma, which harbors NTRK gene fusion in more than 90% of the cases. In similar fashion, secretory breast cancer and so-called mask cancer, they frequently harbor NTRK gene fusions. Congenital mesonephrotic nephroma has also high frequency of NTRK gene fusions in more than 80% of the cases. The cancers with relatively low frequency of NTRK gene fusions include GIST, papillary thyroid carcinoma, and rare variants of malignant melanoma called schizoid melanoma. On my right side of the slide, you can see the common cancers which have low frequency of NTRK gene fusions. These are the results of 3 large large studies that revealed a rare presence of NTRK gene fusions in solid cancers. Overall frequency varied between 0.2 and 0.3% of all tested cases. Please note that these studies involved several thousands of solid tumors. Speaking of NTRK gene fusions and sarcomas, just a brief introduction about sarcomas. There are a heterogeneous group of mesenchymal tumors with more than 50 different histological subtypes that are typically subdivided into soft tissue sarcomas and bone sarcomas. They are very uncommon in adults, around 1%, while in pediatric population, the frequency of soft tissue tumors and bone tumors, it's around 11 to 13% of the cases. Most of sarcomas are not treated with the targeted therapies, but with the classical conventional chemotherapy. There are a few exceptions like gastrointestinal stromal tumor, which has a targeted therapy, while the remaining soft tissue tumors are typically treated with the classical chemotherapy, with a few improvements with newer agents in the previous couple of years. Speaking of the frequency of NTRK fusions in sarcomas, as I said, infantile fibrous sarcoma is at the top with 90% of the frequency. The second most common soft tissue tumor with NTRK gene fusion is inflammatory myofibroblastic tumor, while all other sarcomas have overall low frequency of NTRK gene fusions, around 1%. Also, keep in mind that sarcomas with low frequency of NTRK gene fusions include sarcomas that have complex genomic alterations as well as wild-type GIST. It means GIST that is devoid of common genomic alterations, c-KIT and platelet-derived growth factor receptor. However, there is emerging evidence that a variety of sarcomas may also harbor NTRK gene fusions. So recently published data indicate that NTRK gene fusions can be seen in spindle cell tumors with RAF and BRAF and NTRK1 G fusions in sarcomas that have a similar feature to infantile fibrous sarcomas, lymphofibromatosis like neural tumors, and NTRK3 gene fusion positive sarcomas. There are also recently published papers reporting the presence of NTRK gene fusions in mesenchymal soft tissue tumors of GI tract that are unrelated to GIST, and this is the reference for this statement. A few more studies that recently reported NTRK gene fusions in soft tissue tumors. In particular, there are a group of the tumors that cause soft tissue tumors with spindle cell morphology that co-express S100 and CD34, and they harbor NTRK gene fusions, typically NTRK1 and NTRK2 gene fusions. And this is recently published, very important diagnostic algorithm for the identifying NTRK fusions in soft tissue tumors, and this was provided by the World Sarcoma Network Group. And you can see that this identification is mainly for locally advanced or metastatic or unresectable soft tissue tumors, and they prioritize soft tissue tumors into three categories: those with a high frequency of NTRK fusions, those with a low frequency, and those with a low priority, which are the tumors that are less likely to exhibit one of the NTRK gene fusions. As you can see on the slide, immunohistochemistry is one of the first tests that is used as a screening method, and if positive, immunohistochemistry requires further confirmation by some other methods, which we are going to discuss in the coming minutes. So these are the methods that are used. Mainly it's immunohistochemistry as a screening method. Of course, each of the assays that are provided here is immunohistochemistry, fluorescent in situ hybridization, RT-PCR assays, and NGS assays based on DNA or RNA. Each of them has advantages and disadvantages. However, we will focus here on the screening with Ventana pan-TRK antibody that is now available and that has been shown to have a good sensitivity and specificity in screening and identifying NTRK gene fusions. This antibody actually binds to the shared C-terminus region of TRK proteins. Importantly, this antibody detects both fused and wild type of NTRK proteins. And on the image, you have a nice expression of NTRK protein as determined by the Ventana pan-TRK assay. This Ventana's antibody is optimized, of course, for the Ventana's bench ultra instrument, and it works very good on this immunohistochemical platform. This is the basic information about this Ventana pan-Trk antibody. Of course, as for any other immunohistochemical assay, it's essential to run a proper controls. As I said in the introduction of this brief session, NTRK are typically positive in the brain tissue or central nervous system and peripheral nervous system. So cerebellum is the optimal brain tissue for the positive control, and it typically stains gray matter, while minimal or no staining is present in the brain white matter. So so in the same brain tissue you have both positive and negative control. If you don't use if you don't have proper cerebellum sections, you can have the appendix, which is widely used tissue in surgical pathology, and it typically, an NTRK protein is typically present in nerves and ganglion cells in the appendiceal wall. On the other hand, mucosa, smooth muscle, and lymphoid aggregates within the appendix wall are devoid of NTRK positivity. So either of them are used for the positive control, and they are essential for the proper interpretation of NTRK Ventana immunohistochemistry. Here are a few examples of NTRK positivity in the tumors. As I said, mammary analog secretory carcinoma is a prototype of a highly positive the tumor with NTRK fusions, in this case NTRK3 with ETV partner, and this is typical diffuse and strong nuclear expression of NTRK3 protein by pan-Trk immunohistochemical assay on the image on my right side. Another example is infantile fibrosarcoma with again nuclear expression. The image on my left side shows diffuse and strong nuclear NTRK expression, while the image on my right side shows predominantly a weak to moderate nuclear expression of NTRK3 protein. And these are different staining patterns that you can see with this Ventana pan-NTRK assay, from the cytoplasmic, combined cytoplasmic and nuclear, to the membranous and cytoplasmic expression. So you should realize that the pattern of the expression may vary from the type to the type of the cancer, and depending on the fusion that is present in certain cancer. It's important to know again that the prevalence of NTRK fusions is overall very low. Pan-Trk immunohistochemical localization, as I said, can be nuclear, cytoplasmic, or membranous. It can also be combined. There is no defined cutoff for positivity, how many positive cells you must have to say the certain cancer is positive by immunohistochemistry. Pan-Trk immunohistochemistry is mainly tool to identify potential fusion positive cases. Keep in mind that immunohistochemistry is not optimal assay to differentiate neuroendocrine tumors because they may contain high endogenous staining. However, endogenous staining in cerebellum and appendix, mainly ganglion and nerve cells, can be utilized for tissue controls. Also, tissues that have a neurological smooth muscle differentiation frequently may have a genuine NTRK expression without the presence of NTRK gene fusions on the confirmatory tests. That's why pan-Trk immunohistochemistry should be cautiously interpreted when there is no neurologic or smooth muscle differentiation in certain tumor. Of course, it should be cautiously interpreted with in sarcomas of unknown or with unknown differentiation. Immunohistochemical assay, Ventana's assay, is an excellent screening tool. As I said, the studies have shown very good concordance with the NGS assay. There is a small discrepancy that is mainly seen in detecting NTRK3 gene fusions. For other gene fusions, immunohistochemical assay has been shown to be highly concordant with the NGS data. And the previously provided the paper also recommends immunohistochemistry and highlighting its high sensitivity and high specificity and the ability to detect all fusion genes. Of course, in any case, when you have NTRK gene positivity by immunohistochemistry, it requires additional confirmation by some of the assays. Most preferably, it should be NGS-based assay like Foundation Medicine Hem test, which is comprehensive molecular genomic profiling of the cancer, which can detect all the types of the gene fusions and can also highlight other potential genomic alterations that can be seen in that particular cancer. In summary, Ventana immunohistochemistry pan-Trk test is a reliable, accurate test that is easy to perform and to detect NTRK positive cancers, including sarcomas. There are also recent guidelines or recommendations for diagnosis and management of NTRK positive sarcomas as provided by the World Sarcoma Network. Although no testing algorithms and the companion diagnostic tests are officially approved, clear, strictly defined criteria may help you identifying the NTRK positive cancers, keeping in mind that NTRK gene fusions are really uncommon in common cancers, but are common in rare cancers as previously provided. However, keep in mind when speaking about sarcomas, there is emerging evidence for identifying sarcomas beyond these uncommon types, including sarcomas that have spindle cell morphology, sarcomas with complex genomics, and the spindle cell sarcomas that co-express CD34 and S100. Thank you.
Dear colleague, good day. I would like to thank the organizer for inviting me to be part of today's academy. I'm Inga Marjanovic, Clinical Oncology in University Clinical Hospital Mostar. I will present you how to treat NTRK gene fusion positive sarcoma. Soft tissue sarcomas represent a very heterogeneous set of diseases, and sarcomas is approximately 1 of all adult cancer, rare cancer, and 20% of all pediatric solid tumors. For localized setting, curative management, complete resection with or without radiation or chemotherapy, and for local advanced or metastatic disease or those with disease's recurrence following surgery, treatment options is systemic therapy, radiation, surgery, or ablation techniques. The median overall survival of patients with advanced soft tissue sarcoma about 20 months. We take heterogeneous group of malignancies, sarcoma, soft tissue approximately 18% or bone 20. Umbrella term comprising more than 115 malignant subtypes. Each subtypes represent a unique disease or a subfamily of diseases with distinct biomolecular characteristics and clinical behaviors. Management of sarcomas is challenging. For metastatic advanced sarcomas, they cannot be surgically excised. Prognoses are very poor due to difficulty in finding optimal treatments. Management of sarcoma is challenging due to inadequate diagnosis, limited treatments, and poor prognosis. And we see frequent misdiagnosis and delayed diagnosis at estimate 13 to 15% of initial diagnosis made outside the reference network are incorrect. Available treatments provide limited clinical benefits. In current practice, sarcomas that can be excised are generally treated with cytotoxic agents. Overall, only approximately 25% of patients respond to cytotoxic agents. Many patients face poor prognosis. Approximately 15% of all sarcoma patients develop metastases, even if they are diagnosed at early stage. Metastatic sarcomas result in poor survival. Median overall survival for advanced soft tissue sarcoma is only 15 to 18 months. We know that precision medicine aims to deliver the right drug for the right patient and right time. For metastatic advanced sarcomas that can be surgically excised, prognosis is very poor due to difficulty finding optimal treatment, and it's really improve patient outcome with precision medicine approach. Evidence suggests the NTRK inhibitors may provide clinical benefit in a subset of NTRK fusion positive sarcoma patients, and we know in this slide advanced diagnostic, unique patients, personalized treatment, we have better patient outcome. Increased understanding of tumor biology has been a key factor in personalized healthcare in oncology, and advancing identification of key molecular features, identification of oncogenic drivers, development of targeted therapies, diagnostic, and greater understanding of tumor biology, greater potential to personalized treatment. We know in lung cancer, breast cancer, CRC, thyroid cancer, skin, prostate, and head cancer. Tumor-agnostic therapies represent a paradigm shift in how we understand and treat cancer. And we see common genomic alteration observed in multiple tumor types, and tumor-agnostic on histology-independent treatments we see. Emerging complex biomarkers increase the requirements for comprehensive genomic profiling. Robust screening techniques are required to match patients to appropriate precision therapies. We see genomic signatures like MSI, tumor mutation burden, rearrangement, base substitution, and so on. Increase in tumor-agnostic approvals, as well as approval based on complex biomarkers, and hence need to analyze all tumor types. And we see a larotrectinib and entrectinib for NTRK fusion positive and ROS1 positive tumors, pembrolizumab for MSI high and tumor mutation burden high tumors, and pemigatinib for advanced or metastatic cholangiocarcinoma with FGFR2 fusions. We have two drugs, entrectinib and larotrectinib, two approved NTRK inhibitors. Entrectinib, number of patients in the clinical trial, 121 key trials. Basket trials is ALCA trials, D71, 001, StarTrek 1, StarTrek 2, and StarTrek NG. FDA approval entrectinib in August 2019 and EMA approval in May 2020. Two indication for entrectinib. Entrectinib monotherapy is indicated for treatment of adult and pediatric patients more than 20 years with NTRK gene fusion positive solid tumors. And entrectinib as monotherapy is indicated for the treatment of adult patients with ROS1 positive advanced non-small cell lung cancer not previously treated with ROS1 inhibitors. And for larotrectinib, number of patients it was 114 key trials as NCT 01222913 and Navigate and Scout trial. FDA approval in November 2018 and EMA approval September 2019. Indication for larotrectinib is monotherapy is indicated for the treatment of adult and pediatric patients with local advanced or metastatic solid tumors that displayed NTRK gene fusion. In the study for entrectinib basket trial, 24% patient was with TRK fusion positive sarcoma, and in larotrectinib trial was 45% patient with TRK positive fusion sarcoma. Larotrectinib in TRK fusion positive cancer, we see patient population by tumor type, number of patients we said 114, and we saw soft tissue sarcoma was 19%. Larotrectinib was efficacy regardless of tumor type, and overall response rate was 67%, and in adult patient with CNS metastasis baseline was 73%. Median progression-free survival was 25.8 8 months, and for patients with CNS metastases, 9.9 months. But for entrectinib, we see integrated efficacy and safety analysis for NTRK fusion-positive tumors. In basket trial, we say Star Trek 2-1 ALCA trial. And the primary endpoints in study was overall response rate and duration of response. Secondary endpoints was progression-free survival and overall survival, intracranial overall response rate and duration of response, safety and tolerability. Safety population was patients receiving entrectinib, all tumor types and gene rearrangement, and number of this was 626 patients, include 193 adult patients with NTRK positive, TRK inhibitors naive solid tumors who received more than one dose entrectinib. And the efficacy population include 121 patients with 14 different tumor types. We see number of patients with sarcoma was 26. Age of patient was 57 years old. ECO performance status was 0, 43.8%, 1, 47.1, and 2, 9.1%. Prior lines, we see 1, 28.9%, and more than 2, 14.5%. About 17% of patients. And CNS at the baseline was 21.5 patient. And entrectinib was associated with deep and durable responses and long survival in NTRK fusion positive tumors. And we see overall response rate was in efficacy population 61.2%, baseline CNS metastases 57.7%, and no baseline CNS metastases 62.1%. Patient with complete response was 15.7%, with CNS metastases 7.7%, and without CNS metastases 17.9% of patients. Median time to response was 1 month. Median duration of response was efficacy population 20 months. Median progression-free survival was 13.8 months, and median overall survival was 33.8 months for efficacy population, with CNS metastases 19.9% of patients, and without metastases CNS 37.1 months. We have very fast response with entrectinib. Responses with entrectinib by tumor types, we see sarcoma, number of patients was 26, and overall response rate was 57.7%. Duration of response was 15 months. We saw sarcoma types included in listed here. Responses with entrectinib by tumor types in waterfall plot in this slide, we saw responses with entrectinib with complete response and partial response. Number of patients was 74, stable disease, number of patients 13, and we saw underlying few of patients with progressive disease. We saw in this slide CT scan one of patient, 48-year-old man with TPM3 and NTRK positive sarcoma, and we see in July 18, 2016, after 37 days with therapy with entrectinib, August 24, 2016, tumor is gone. In the end, current treatment guidelines for advanced NTRK gene fusion positive soft tissue sarcoma, NCCN guidelines, ESMO guidelines, say larotrectinib and entrectinib are recommended for first-line treatment for NTRK gene fusion positive advanced metastatic soft tissue sarcoma. And ESMO guidelines, NTRK inhibitors are standard treatment of patients with advanced NTRK rearranged sarcoma. They can be considered also in the preoperative setting when a cytoreduction can improve morbidity and function. Identify rare NTRK gene fusions which have therapeutic implication. Finding patients with NTRK fusion is difficult. For metastatic advanced sarcoma that cannot be surgical excised, prognoses are very poor due to the difficulties finding optimal treatments. Treatments with emergent drug inhibitors like larotrectinib and entrectinib may be transformative, leading to fast and durable responses. Improve patient outcome with precision medicine's approach. Evidence suggests that NTRK inhibitors may provide clinical benefit with a subset of NTRK fusion positive sarcoma patient. Put sarcoma to the test. Thank you.